Bismillahirrahmanirrahim. Assalamu alaikum. Dear PGs and colleagues, today is 19th February, and inshallah, Ramadan will commence after 9 or 10 days. At this time, the most frequent question which is asked from us is by the relatives or by the patients of liver cirrhosis that they want to keep fast or if they can fast during the Ramadan or not. Ramadan and cirrhotic patients, it's not a simple and straightforward question or straightforward matter. You have to think about many factors. You have to analyze the many aspects, and then you advise the patient whether the patient can fast or not during the Ramadan. So for this purpose, I'm starting a workshop of liver cirrhosis in Ramadan, and this workshop consists of a couple of videos, and we will explore the different aspects of this issue, the liver cirrhosis in Ramadan. So today is the first introductory video, and then we will discuss a couple of case histories, real-world case histories, and then we will explore the different aspects of the liver cirrhosis in Ramadan. Fasting during Ramadan and liver cirrhosis. This workshop will answer the key question: can patients with liver cirrhosis safely fast during Ramadan? If yes, under what conditions? And if not, how do we advise them compassionately? We know the Islamic perspective on fasting. There's religious flexibility, and we see the Quranic allowance for the sick to postpone or skip fasting through Surah Al-Baqarah, Ayat 185. The patient concerns. Importance of balancing religious obligations with health. Most of the patients, they want to fast. And this becomes the responsibility of the caring physician to assess, to evaluate whether the patient can fast or not. And at times, such patients come to us and they want to avoid fast and ask the doctor to confirm that yes, they cannot fast. And in fact, their condition is stable and they can fast. So it's the both way. Patients most of the times want to fast, but the fasting can be deleterious to their disease. And at times the patient don't want to fast, but the disease is stable. So this decision by the doctor whether the patient can fast or not is very, very critical and important religiously as well. So this workshop on fasting during Ramadan and liver cirrhosis will discuss the implications of fasting during Ramadan for patients with liver cirrhosis, highlighting the potential risks and benefits, and providing guidance for healthcare professionals. This workshop has 5 main sections. Section number 1, it is about introduction and background of the issue. Section number 2, we will see the physiological changes during fasting. We'll discuss what are those physiological changes during fasting. In the third section, we will discuss risks and complications of fasting in liver cirrhosis. In the fourth section, we will discuss precautions and recommendations for fasting in liver cirrhosis. And in the fifth section, we will see the conclusions and future directions for this issue. In the first section on introduction and background, we will revise and we will assess the definition of liver cirrhosis. We know it's a chronic liver disease characterized by fibrosis and scarring of liver tissue. We will see the prevalence of liver cirrhosis. We know estimated global prevalence and common causes, viral hepatitis, fatty liver disease, alcohol consumptions. So we will have an overview of these. And then we will have an overview of the benefits and risks of fasting during Ramadan for patients with chronic medical conditions. So the Ramadan fasting and health. In the second section on physiological changes during fasting, we will discuss metabolic changes, how there's a shift from the glucose to ketone metabolism, and implications for liver functions. We will have an overview of the fluid and electrolyte balance, the risk of dehydration and electrolyte disturbances, particularly in patients with cirrhosis. And what are the hormonal changes during fasting? So the impact of fasting on hormone levels, including insulin, glucagon, and cortisol. In the third section on the risks and complications of fasting in liver cirrhosis, we'll discuss the dehydration and electrolyte imbalance issue. There's increased risk of dehydration and electrolyte disturbances in patients with cirrhosis. We'll also touch upon the hepatic encephalopathy, the risk of worsening hepatic encephalopathy due to changes in gut flora and ammonia metabolism. The variceal bleeding issue, the potential increased risk of variceal bleeding due to changes in blood pressure and volume, and worsening of liver functions. Risks of worsening of liver functions, particularly in patients with advanced cirrhosis. In the fourth section on precautions and recommendations for fasting in liver cirrhosis, we'll discuss about the pre-fasting evaluation, the importance of pre-fasting evaluation, including assessment of liver functions, electrolyte levels, and overall health status. The second important aspect in this section will be hydration and electrolyte management. What are the strategies for maintaining adequate hydration and electrolyte balance during fasting? And then we'll discuss about the monitoring and follow-up, the regular monitoring and follow-up to detect potential complications early. And of course, the alternative fasting options. We'll discuss these, like discussion of alternative fasting options such as shorter fasting periods or exemptions from fasting. And in the fifth and final section on conclusions and future directions, we will see the summary of key points. We'll recap the main points discussed in the workshop. And what are the future research directions, like identification of areas for future research, including studies on the effects of fasting on liver function, and the development of evidence-based guidelines for fasting in liver cirrhosis, and the clinical implications. It includes discussions of the clinical indications of the workshop. We'll discuss these, including the importance of individualized assessment and management of patients with liver cirrhosis who wish to fast during Ramadan. Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the second episode of our workshop on liver cirrhosis and Ramadan fasting. This session is designed for medical students, postgraduate students, and doctors, providing an in-depth analysis of real patient cases. We shall explore how fasting during Ramadan affects individuals with liver cirrhosis, discussing clinical outcomes, risks, and management strategies based on current medical evidence. Whether you are in training or clinical practice, today's lecture will enhance your understanding of this important topic. Let's get started. We shall discuss three case histories today. The first case history, I have titled this as Tailoring Fasting Recommendations. It's a case history of Mr. Ahmed, 52 years of age, with HBV-related compensated liver cirrhosis. CTP score A with 6 points. He's also having type 2 diabetes and mild hypertension. His current medications include entecavir for hepatitis B, metformin for diabetes, and amlodipine for hypertension. On pre-Ramadan visit, Mr. Ahmed consulted his physician a week before Ramadan to discuss fasting. He expressed a strong desire to fast, citing spiritual and personal reasons. And this is with most of our patients. You agree? His medical history and recent labs revealed stable liver tests, controlled blood pressure and blood glucose, no evidence of ascites, hepatic encephalopathy, or significant malnutrition. The physician explained the risk of fasting for cirrhotic patients, including dehydration, hypoglycemia, and potential metabolic stress. However, given Mr. Ahmad's stable condition, compensated cirrhosis, child score A, and strong motivation, the physician agreed to allow fasting with specific precautions. And these specific precautions were dietary plan. In Suhoor, that is the pre-dawn, he should consume high protein, low glycemic index foods, and plenty of fluids. And in the iftar, the post-sunset meal, he should use balanced meal with adequate calories, avoiding fried or salty foods. Regarding hydration, he suggested that Ahmad should drink at least 2.5 liters of water during non-fasting hours. Regarding blood glucose monitoring, he was advised to check blood sugar levels during fasting hours to prevent hypoglycemia, and to break the fast immediately if blood sugar fell below 70 milligram per deciliter. Regarding medication, he adjusted metformin timings to iftar and suhoor and encouraged skipping fasting on days when feeling unwell or excessively fatigued. During Ramadan, Mr. Ahmad adhered to his physician's advice. He fasted successfully for the first 10 days of Ramadan, reporting no major symptoms. Midway through Ramadan, he started experiencing fatigue and mild dizziness. Blood sugar checks revealed levels around 68 milligram during fasting hours. After discussing with his physician, he skipped fasting for 3 days to recover and increased his hydration during non-fasting hours. He resumed fasting for a few more days but chose to avoid fasting entirely in the last week of Ramadan due to persistent fatigue. Post-Ramadan follow-up of this patient. At his post-Ramadan follow-up, Mr. Ahmad showed no signs of liver decompensation. However, he had lost 2 kg during the month, and his physician emphasized the importance of maintaining adequate nutrition and hydration in the future. Lessons learned from this case history. Fasting is possible for selected cirrhotic patients. Stable patients with decompensated cirrhosis, child score A, may tolerate fasting under close monitoring and adherence to medical advice. Importance of flexibility. Patients should be educated to recognize warning signs, for example, dizziness, fatigue, hypoglycemia, and skip fasting when necessary. Physician's role in such cases, individualized assessment and ongoing support during Ramadan are critical, and the physician should be ready for it. Physician should encourage alternative religious practices for patients unable to fast safely, the fidya and the other ibadats. Takeaway message from this case history. This case highlights the importance of tailoring fasting recommendations to each patient's clinical status, educating them on the risks, and maintaining open communication during Ramadan. The second case history, and the title is Critical Role of Patients' Education and Proactive Management. This is the case history of Mr. Samir, 58 years of age, with HCV-related decompensated liver cirrhosis. Child score B with 8 points. His symptoms are ascites controlled with diuretics, occasional fatigue, but no encephalopathy. His medications include spironolactone and furosemide for ascites, Lactulose for ammonia reduction, and carvedilol for portal hypertension. The pre-Ramadan assessment, Mr. Samir visited his hepatologist a week before Ramadan. He expressed a strong desire to fast despite his condition, citing the spiritual importance of Ramadan. During the consultation, the doctor explained that fasting poses significant risks due to his decompensated cirrhosis, including dehydration, electrolyte imbalance, worsening ascites, and hepatic encephalopathy. Mr. Samir insisted that he would monitor himself closely and break his fast if necessary. His doctor reluctantly agreed, but emphasized that fasting was not advisable. A detailed plan was provided to minimize risks. Fasting during Ramadan, despite medical advice, as I said, Mr. Samir began fasting from the first day of Ramadan. He followed these precautions regarding dietary adjustments, consumed a nutrient-dense meal at Sohar, including high-protein foods, complex carbohydrates, and fluids. He avoided salty and fried foods to reduce fluid retention and minimize strain on his liver. He drank 2 liters of fluids between the iftar and suhoor as hydration strategy. He took diuretics after iftar to avoid dehydration during fasting hours. And the lactulose dose was adjusted based on bowel movements to prevent encephalopathy. Complications midway through Ramadan. By the second week of Ramadan, Mr. Samir began experiencing symptoms, increased fatigue and weakness, dizziness and lightheadedness during fasting hours, reduced urine output suggesting worsening dehydration. On the 12th day of Ramadan, his family rushed him to the emergency department after he became confused and lethargic in the afternoon. Laboratory tests revealed significant electrolyte imbalance, hyponatremia, and hypokalemia. Elevated ammonia levels indicative of hepatic encephalopathy. Mr. Samir was admitted and treated for hepatic encephalopathy in the hospital. He was rehydrated with IV fluids and electrolytes. Diuretics were temporarily withheld to stabilize his condition. Lactulose was adjusted to lower ammonia levels. After discharge, his hepatologist strongly advised against resuming fasting. The following points were emphasized. Religious flexibility. He was told the Quran exempts the sick from fasting, and Islam prioritizes preserving life and health. Mr. Samir could compensate by feeding the needy for each missed fast. We now call it fidya. Health risks. His worsening dehydration and encephalopathy demonstrated that fasting was incompatible with his medical condition. Mr. Samir agreed not to fast for the remainder of Ramadan and expressed gratitude for the care he received. Take away points from this case history. In decompensated cirrhosis and fasting, patients with decompensated cirrhosis face severe risks when fasting, including encephalopathy, dehydration, and metabolic imbalances. Fasting should be strongly discouraged in these patients. Communication with patient is very, very important. Respect patients' religious beliefs and provide compassionate explanation of the risks. Never be very rigid. Empathize the patients. Offer alternatives such as religious exemptions and charitable acts to fulfill spiritual obligations. Explain the fidya option. Monitoring. If a patient insists on fasting, ensure close follow-up and provide clear warning signs for breaking the fast or seeking medical care. Conclusion. This case underscores the critical role of patients' education and proactive management for cirrhotic patients during Ramadan. Physicians must balance cultural sensitivity with evidence-based medical advice to protect patients' health. The third case history, and the title is Thorough Pre-Ramadan Assessment and Patient Education. It's a case history of Mr. Khalid, 46 years of age, with muscle-related compensated cirrhosis. with child class A 5 points. His symptoms include mild fatigue, no ascites, and no hepatic encephalopathy. Medications he using: multivitamins and supplements for nutritional support, propranolol for mild portal hypertension. The pre-Ramadan visit. Mr. Khalid approached his doctor to discuss fasting during Ramadan. He was highly motivated to fast given his stable condition and spiritual commitment. During the consultation, his physicians performed a thorough evaluation, including liver function tests and nutritional status. Results indicated that his condition was stable. The risks of fasting were discussed, such as dehydration, hypoglycemia, and malnutrition. The doctor emphasized the importance of close monitoring and adherence to medical advice if fasting was attempted. The physicians approved fasting with specific precautions. The dietary plan given to him was: in Sohr, he should take high protein foods, eggs, yogurt, complex carbohydrates like oats, whole grain bread, roti, and hydration. In iftar, he should use balanced meals with adequate calories, avoiding heavy, greasy, or salty foods. Snacks during non-fasting hours to meet caloric needs. Regarding hydration, he was advised to drink at least 2 liters of fluids between iftar and suhoor. And the medication adjustments: propranolol dose was adjusted to iftar time to avoid potential hypotension during fasting hour. Regarding monitoring, he was asked to check frequent glucose checks during fasting hours and immediately cessation of fasting if symptoms like confusion, dizziness, or extreme fatigue occurred. Experience during Ramadan. Mr. Khalid began fasting from the first day of Ramadan. For the first week, he tolerated fasting well, experiencing only mild fatigue by late afternoon. Midway through Ramadan, around the second week, Mr. Khalid noted increasing tiredness and mild dizziness before iftar. His family physician recommended the following adjustments: reduce physical activity during fasting hours to conserve energy, increase calorie intake at iftar and suhoor to prevent malnutrition, continue monitoring blood glucose. He followed these recommendations and resumed fasting without significant issues. Challenges in the final week. In the last week of Ramadan, Mr. Khalid experienced mild dehydration symptoms, including dark urine and dry mouth, slightly elevated liver enzymes during routine blood tests. The physician advised him to skip fasting for the remaining days to avoid complications. Mr. Khalid reluctantly agreed, choosing to perform religious compensations, that is, feeding the needy fidya instead. Post-Ramadan follow-up. At the follow-up visit, Mr. Khalid reported no major complications during Ramadan, a weight loss of 1.5 kg, prompting the doctor to stress the importance of maintaining nutritional status in the future. Lessons learned from this case history: fasting in compensated cirrhosis. Patients with stable liver function and good nutritional status can fast under medical supervision. Adherence to dietary guidelines and hydration is essential for avoiding complications. Symptoms like dizziness, fatigue, or dark urine indicate dehydration or early complications and should promptly cessation of fasting. So recognizing warning sign is very, very important. flexibility and religious accommodations. Patients should be prepared to skip fasting if health deteriorates. Physicians should reassure patients that Islam allows flexibility for the sick. Takeaway points from this case history. Thorough pre-Ramadan assessment and patient education are critical for safe fasting in cirrhotic patients. Physicians should provide individualized fasting plans and monitor patients closely during Ramadan. Recognizing when to advise patients to stop fasting can prevent serious complications. Bismillah ar-Rahman ar-Rahim. Welcome back to the channel. Today, we are diving into an important topic, cirrhosis and how it relates to fasting during Ramadan. Many people with liver disease wonder whether fasting is safe for them, what precautions they should take, and how to manage their health during this holy month. In this video, we shall explore the medical aspects of cirrhosis, the potential risks of fasting, and expert recommendations to help those affected make informed decisions. Stay tuned for valuable insights. As said in the intro, from today we are formally starting our discussion on the workshop. In today's video, I shall introduce you this workshop and we will see what background is there to embark on this workshop. In the first video, I shared with you the workshop overview that it contains 5 sections. We are in the first formal section of this workshop, titled Introduction and Background to the Workshop of Liver Cirrhosis in Ramadan. And this has got 3 main domains or areas to be discussed: the definition of liver cirrhosis, prevalence of liver cirrhosis, and Ramadan fasting and health. It's just the recall of our basics, the definition of liver cirrhosis. Cirrhosis may be defined as progressive scarring of the liver due to chronic liver injury, leading to impaired liver function. And we know because of the different etiologies, the normal liver, which has got no fibrosis, it starts changing into a fibrotic liver with F1 fibrosis, F2 fibrosis, F3 fibrosis, and ultimately F4 fibrosis. And the regenerative nodules plus the F4 fibrosis is equal to liver cirrhosis. The scarring is often the result of chronic inflammation, which can be caused by a variety of factors. Just to recall, these factors are viral hepatitis B, viral hepatitis C, viral hepatitis D, and immunocompromised people, viral hepatitis E. Then fatty liver disease or metabolic dysfunction associated steatotic liver disease. And this is going to replace all the other etiologies of liver cirrhosis in the coming years. Then autoimmune hepatitis, it can lead to liver cirrhosis. Alcohol consumption, this is one of the major causes of the liver cirrhosis worldwide. Then metabolic or genetic disorders like Wilson disease and hemochromatosis. There's irreversible architectural changes and compromised liver function. So we see 2 main changes in the liver. One is its architectural impairment, and that is irreversible. and second is the liver functions gets compromised. There are two stages of liver cirrhosis. One is the compensated cirrhosis. When liver retains the essential functions, patients may be asymptomatic in this stage. And then decompensated cirrhosis, when we see clinically jaundice, ascites, hepatic encephalopathy, variceal bleeding, and it is associated with increased morbidity and mortality. The mean survival in the compensated cirrhosis is around 10 to 12 years, and in the decompensated cirrhosis, it is reduced to 2 years or less. There are physiological changes in cirrhosis, and what are those changes? There's reduced glycogen storage, and there's impaired gluconeogenesis. And of course, there's the risk of hypoglycemia, malnutrition, and dehydration. So because of these physiological changes in the cirrhosis, when the cirrhotic patient fasts, it gives rise to challenges, or it brings the challenges, and these challenges are reduced glycogen storage, impaired gluconeogenesis, so the risk of hypoglycemia, malnutrition, and dehydration is increased. What is the prevalence of liver cirrhosis? As referred to the recently published article in 2023, it's a review article entitled The Global Epidemiology of Cirrhosis, Etiology, Trends, and Predictions. And I'll suggest that when free, you do go through this article. This is a beautifully article, the latest article, and it gives you the overview. It reviews the data, the global data regarding the epidemiology, its etiology, what are the trends, and what are the predictions for the coming years. So in the Global Burden Disease Study 2017, which this article refers, and the worldwide there are 112 million people affected with cirrhosis. So in the world, 112 million people, they are affected with cirrhosis. And this comes 1,395 cases per 100,000 population. So it's a very common disease. There are 1.5 million deaths of cirrhotics per year in the world. The prevalence of liver cirrhosis varies widely depending on the region, with the highest rates found in Africa and Asia. This study, it summarizes the etiology of cirrhosis from 1993 to 2021. And this figure from this review article I'm sharing with you, it has divided the world into different regions where the predominant cause of etiology, what is the red, it shows the alcohol. These countries, they are the commonest cause of the liver cirrhosis is alcohol, those areas which are highlighted in the red color. Then comes the hepatitis B, the China, the India, and all these. So these are the areas where the commonest cause is hepatitis B. Then comes the yellow, the hepatitis C. These are the areas where hepatitis C related liver cirrhosis is the most common cause, or the most common. And Pakistan is here. In Pakistan, when a patient is found to be cirrhotic patient, this is hepatitis C unless proven otherwise. And the data not available, these are the gray area. So the globally, the commonest cause is the liver of liver cirrhosis is the alcohol, then the hepatitis C, the yellow, then the hepatitis B. So these are the most common causes. And as I told you, in the coming years, probably the whole colors, they will be changed to another color that will be the fatty liver disease. But this is the data from 1993 to 2021. So the predictions is, and what is the going to be the future, probably this will be the MESL, metabolic dysfunction associated liver, steatotic liver disease. Previously, we are calling this fatty liver disease or NAFLD, non-alcoholic fatty liver disease. Then again, this MAPE, the same MAPE, this was regarding the dominant reported etiology of cirrhosis from 1993 to 2021. And this, now the color here, it tells estimated age, standardized death rates due to cirrhosis in 2029 by country. Again, the world has been divided into different colors. The lightest color is where it is less than 10 per 100,000 population, then 10 to 20, then 20 to 30, then it's the 30 to 40 in Pakistan is in this region, then the 40 to 50 and above 50. So the whole world has been divided into different, and in Pakistan, this is the risky country with the risk of the liver cirrhosis. It's very high over here. And I remember a decade or 15 years ago, an article was published in Lancet and stating that Pakistan has become the cirrhotic liver country. So liver cirrhosis is one of the commonest causes here in Pakistan. So this is another study, the global, regional, and national burden of cirrhosis by cause in 195 countries and territories from 1990 to 2021, a systematic analysis of the global burden disease. This is that study which the previous study was giving reference, and this was published in 2020. And according to this again, the prevalence of compensated cirrhosis per 100,000 population, this is the prevalence. And again, they have divided the world into different colors. So the Pakistan is lying over here, where the prevalence of compensated cirrhosis per 100,000 population is 500 to 750. So the darkest color is where it is 290 to 500. These, then the second comes 500 to 750. These then becomes the 750 to 1000. These then becomes the 1000 to 1250. So in Pakistan, the prevalence of compensated cirrhosis per 100,000 is from 500 to 750. And this is the prevalence of decompensated cirrhosis. Previously was the compensated cirrhosis. And this is the decompensated cirrhosis. And this is the 40 to 75. This is the prevalence. That's 40 to 75 cases per 100,000 population here in Pakistan. So the liver cirrhosis is the common finding. And what we see, the decompensated cirrhosis is common over here as well. Again, death rate in cirrhosis per 100,000 population, according to that Global Burden Disease Study 2017. This is the Pakistan. Here it is 3 to 9 cases per 100,000 population. They die because of the liver cirrhosis. With recalling the basics of the liver cirrhosis and the prevalence of the liver cirrhosis in the world and in Pakistan, the Ramadan fasting and health is a fundamental aspect. We know Ramadan is the fundamental aspect of our Islamic practice, where we Muslims fast from dawn to sunset for 29 to 30 days, depending upon the lunar month. While fasting can have spiritual and health benefits, it can also pose risks for individuals with chronic medical conditions, including liver cirrhosis. And that's the reason we have started this workshop. In the next episode, we shall discuss the physiological changes during fasting, that in the normal person, what are the normal physiological changes. And after this, we will compare that with the cirrhotic patient, that how the cirrhotic patients has those challenges or those issues, and then we will proceed how to treat these patients.